Thanks everyone. It's quite an interesting group today, and it's lovely to follow all of your stories. I, like you, Joyce, have a real passion for this, as will hopefully come through our presentation. So I'm Bernie. I am the service lead for tissue viability in Birmingham community, and exactly like you, Joyce, it's a very diverse patch. I come from a train of thought where we were always drummed into us, react to red, darker skin's never going to go red, and it's just changing our whole resources to enable us to do that. And this is my lovely colleague Sally, who was the manager of the unit where we undertook this study. Again, there's no, I've got no declaration of financial interest or relationships. So we all know, everybody in this room knows the huge cost of pressure ulcers and what they pose to the NHS. We all know it's increasing into billions of pounds, and the management of it is an ever-growing cost that we're having to continually manage. We all know prevention is better than cure. We all know that patients are living longer and presenting much later with skin changes. COVID was a massive indicator of this, where people weren't presenting until they had a cavity by the time they accessed the services, and that was well known. Harm-free agenda, top 10 harm from the quote from this morning. Prevention is better than cure. I met a chap last week, and it was really interesting to listen to the patient story this morning from Claire, when she talked about the district nurse came in and she had 4 minutes allocated, and that was to look at the abdominal wound. So everything else just went by the by. And I know patients like that. I had a chap last week who was admitted with sepsis for a leg. In his lower leg he had cellulitis, which led on to sepsis. He, in between lucid periods, was saying, I need to be on an air mattress, I need to be on an air mattress, I need to be on an air mattress, and nobody listened. And this is a real recent case, and so now we're going out, he's got a category 4, and his first words to me were, this could have been prevented. And I totally agreed, and so that's my next patient story. So hopefully he might come to this event next year, you never know. The SEM scanner, I know everybody's talked about that, so I won't go into the details of how it works, but how our journey led us to the SEM scanner and to work with our colleagues was around the work we were doing around the darker skin tones. We were looking at trying to recognise skin damage much earlier, particularly in our dark skin cohort, and we were approached. But at the time we were also doing another project, which is why we didn't take it to the community, on the discharge of the at-risk. So whilst we're talking about prevention, I mean, we'll probably resurface in a few years' time and see all these pressures that developed because the district nursing services have discharged them. But we will probably see that, but we're discharging them and going down that self-care approach. So it wasn't deemed that we could use this at the time, we could use this in our district nursing care. So then along came Sally, and we thought, actually, we have got somewhere we could use this. So we will, and it was a really good outcome. It's very similar to your results in what we found, and we would like to shout about the results and how good they are. And I think, like you, they speak for themselves, and you can't put a price on that cost of that admission to the patient and how they feel. Where to scan, that's already been discussed as well. And so how we ran this was we run on, we know our numbers, we know our peaks and troughs, we know when the numbers go up of our pressure ulcers, hospital-acquired pressure ulcers. We run at around an incident of 7.1%. That increases over winter pressures. It goes as high as, quote me if I'm wrong, Sally, it went right up at Christmas, 17?
I think it was,
it went to 17, which panic, alarm bells were ringing, and I listened to somebody earlier and theirs went up to 74. I think I'd be crying if I had someone coming to me saying there's 74% incident. So Willow House is a palliative care unit that sits on our community hospital site, and it's quite an interesting unit for exactly those reasons we would expect our palliative care patients. Well, it's expected, your skin's going to shut down, you'll get a pressure ulcer, and we all presume that skin changes towards life end. We're almost expecting it to happen for this cohort of patients. We identified that there were 13 hospital-acquired pressure ulcers from March 21 to March 22. Number of admissions in that prior period were 182. It's an 18-bedded unit, and the average length of stay is 28 days. The SEM scanner evaluation, I will just add that the pilot took place during the roasting hot period of weather that we had last summer, the start of last summer, so it was a really good time for us, wasn't it? It was like 36, 37 degrees, and it was like, great. And Jane, I'm not sure she's in the room, but Jane's supporting us, and we were all hot at the time.
Very hot at the moment.
And the evaluation period was over that 6-week summer period, which again factors in that staffing numbers are low during that period of time with annual leave, so we're already up against some barriers as it stands. 35 patients were scanned in total. Everyone was scanned, regardless, every patient that was admitted was scanned, other than if they already had a pressure ulcer, so everybody was scanned. Patients were scanned for 7 days over the week. In total, 795 readings were taken. Patients were scanned on average for 28 days, minimum of one times a day and the maximum of 42 days. In 73% of the patients that were scanned, the readings were over 0.6, so over that vital mark. And 33% there was no visual discoloration noted, and for 43% of the patients, the nurses reported that going on that reading alone, it changed their decision making, and it was a real empowering tool for the staff as well. So in 43% of the patients, the nurses noted that the use of the scanner changed what they were going to do and what they did. So it's really simple stuff, and everyone in this room knows that. Increasing that repositioning, looking at the surface, did you introduce a mattress, was heel support or elevation of the heels introduced, and was a prophylactic dressing or barrier cream introduced. And it is all, like you said at the very beginning, it's all our prevention. But now we have a reading that's telling us we need to do this now. And this is the first time we've got that sort of evidence to sort of support what we're doing. It's exactly like you said, some people develop a pressure ulcer, some people won't. So the number of ward admissions during this particular period was 16 patients, and like yourself there, we had 0 hospital-acquired pressure ulcers during this period of time, during the evaluation period, and the prior incidence, as we said, was 7.1. So this is a fantastic result for us. It was 100% reduction in the incidence of pressure ulcers during that period of time, and exactly like yourself, it's really empowering for the staff and for the patients to know that what we're doing is the right thing and but no one's getting any harm during the admission. So exactly like you, we homed in on the darker skin to see what we were doing and could we see anything. It's well known that darker skin presents later on. We're not as sharp at looking at the visual tools. We are trying, we're improving, we're looking at the maroon, the bruise light, we are trying, but getting that across to all of the staff is quite a slow process. So this did aid that. There were 3 darker skin toned patients during the admission, and no skin redness was noted, as you wouldn't expect. High delta readings, and the implementation staff implemented the targeted relief measures at the time, and it worked really well. And the feedback from the ward staff, and I will add here, it was exactly like the lady here. It was the healthcare assistant that was really pivotal in this. Sally's team, the nurse would, we delivered a lot of training, but it was that person on the ground, that healthcare assistant that was doing this, that was doing that. And once they were engaged and on board with it, it worked fantastic. And they did lead this, and without them, we wouldn't have these results.
They absolutely ran with it, and it just so improved their engagement, their knowledge around maintaining skin integrity, their interest in the subject. I think before the pilot, it was very much seen. Sorry. Before the pilot, it was, I think, skin integrity was seen as a nurse's job, and it's now much more of a team approach, and it really has empowered our HCAs. And the pilot wouldn't have been a success. We ummed and ahed at the start whether to for the scanners to be kind of the responsibility of the nurses, and decided against that, and I'm so glad we did, because without their sign up, without the sign up of the HCAs, we wouldn't have had the results that we did, because we wouldn't have had the consistency of the scanning, because they were absolutely pivotal and continue to be pivotal in that.
Just a little bit of feedback from the ward staff there. It's easy, and I think for anyone that's working clinically at the minute, anything that's easy, people are going to run with. They don't want something that's going to take time. It's going to be really difficult to interpret, really difficult to use. Easy. I found it helpful for the staff to identify if the skin of the patient is at risk. It's a great piece of equipment, easy to use and efficient, provides extra information for me when making clinical decisions, And most staff will struggle with the bottom point. What do I do? I've got this reading, and it just supports that judgment. I find it interesting. I'd like to know the feedback of when your carers contacted the district nurses and that, yes, there's nothing visual, what the response was. I'd find that quite interesting to see what the response was at the time. And so where are we now? So the evaluation of the outcomes of that, it's a busy intermediate care unit. 57% of interventions included the specialist mattresses. We do use a hybrid mattress, so you have a foam mattress, and once that level of risk goes up, you switch the pump on before you switch to the full dynamic system. And it was, people were going straight for just using the foam. They weren't using the hybrid aspect of it. They were going straight to a dynamic once the damage had set in. So it did really revisit the use of those more appropriately. Yeah. Healthcare assistants identifying the patients, that was brilliant, and then escalating it to the nurse who was on shift. And the responsibility, like Sally's outlined, must fall, previously they felt it must fall with the registered nurse, but actually it's the whole team. And now it's become embedded into the daily routine and the daily skin checking. And then what we've done is we're trying to, which any trust struggles with this, is digital documentation. That's our next step with it. We are rolling it out because Sally's unit is not just a standalone unit. There's 2 community hospitals. We've got 2 intermediate care unit sites. Exactly the same. We had high readings in March, April. There was a panic button. Can we roll this out tomorrow? And that's where we're at. We're in the rollout of it. Like yourself, we've developed a SOP and a new interventions policy for this. Presenting full feedback, our divisional quality groups. Identification, they're the hotspot areas where we know we need to go. And developing a plan for adoption. For me, as the service lead for tissue viability, I see a real move for this tool. We cover children and families. There's a palliative care team within that. I really feel we can make real good progress with this tool, and we can really help moving forward in that reduction of our pressure ulcers. So thanks for listening.
Super, well done.